Hi everyone, my name's Caroline. I'm going to be getting started at 1 p.m. In the meantime, why doesn't everyone share where they're from, where they're watching from? Maybe if they're from a school, what school are you from? Please share your name in the Q&A or the comment section and I'll give you guys a shout out. I have Carolyn from Bayville, Aria from NYC Peck Slip School. Welcome, thanks for joining us. Christopher and Samantha Mora, welcome, thanks for joining us for today's lesson. We have Luna and Rosa from Richfield Park. Bree from New Jersey. We have someone watching from Lake Ridge, Virginia. Bella and Angela, hello, welcome. And Martin from PS222 in Brooklyn, New York. We have someone from Jersey City, welcome. Staten Island, New York, Curtis High School Nursing Program. Welcome. And welcome to our future nurses. Tanya from Paterson, New Jersey. Prakeet from Delaware. We have a lot of people from everywhere. Neptune, New Jersey. Someone else from Bayonne. Hi, Farron. We have a lot of Bayonne, a lot of New Jersey. Really close to us here in Jersey City at the Science Center. Edward and Scott. Lauren from Jersey City. We got a lot of Jersey City joining us for today's lesson. We're going to give it another minute or two before we get started. We have another nursing student at Essex County College. Congratulations to another one of our future nurses. So Amanda asked what kind of surgery we're seeing today. So we're going to be going over some risk factors on cardiac surgery and different forms of heart disease. Oh wow, Tony Ann from Galloway, New Jersey is a former recipient of open heart surgery. Thank you for joining us. I hope that you enjoyed today's lesson. We have someone from Princeton, New Jersey, Old Bridge. I'm going to give about one more minute till we get started here. Vincent from Old Bridge in New Jersey. Awesome, thank you all so much for joining us. So who here has been to the Liberty Science Center before? Do we have any viewers who have came to the Science Center before? Okay. We have Sophie who joined us here. Okay, we have a lot of viewers for today's lesson. Okay, so it's about 1:01, so I'm going to get started. So, welcome everybody. My name is Caroline. I'm one of the distance learning specialists here at the Liberty Science Center under our STEM education department. One of my jobs as a distance learning specialist is working in our Live from Surgery program. That program, if you're not familiar with it, invites high school and middle school students to the Science Center on a field trip to watch a surgery live in time. We have partnerships with hospitals all across New Jersey where we present all different types of surgeries, such as kidney transplant, heart transplant, neonatal, open heart, neurosurgery, robotic surgery, you name it. So today we're going to be participating in learning about heart risk factors, a little bit about heart disease, cardiac surgery, different treatment options. I'm going to be switching through different screens throughout my lesson, and one of my colleagues is going to be answering questions in real time throughout this live stream in the Q&A section. So feel free to ask any questions. If I'm not able to get to them, one of my colleagues will get to them in the meantime, or just hold on to your questions till the end and I'll be doing a live QA session. So we're going to be going over heart risk factors, a little bit about coronary artery disease, all that's associated with our heart surgery program here at the Science Center. And with that surgery, we're partnered with Morristown Medical Center, which is an Atlantic Health System hospital. So let's begin by talking a little bit about how the human heart works. Our hearts, that are about the size of our fists, are one of the most important organs in our bodies. It beats more than 100,000 times a day, pumping about 2,000 gallons of blood throughout a 60,000-mile network of blood vessels in our bodies. Our hearts have a lot of parts to them, so let's dive into a little bit about the anatomy of the heart. So when we're talking about the heart, we're going to want to keep track of the heart split into two parts, the left side of the heart and the right side of the heart. You can either use me on screen here or the diagram to follow along with the explanation of the anatomy. So we have a few chambers of the heart that are associated with muscular pumps. I can actually open them up here on my model. We have our right atrium on this side. That's labeled RA on the diagram in the PowerPoint. Our left atrium on top right here on our left side. And then on the bottom, our right ventricle, that opens up right here. And our left ventricle here at the bottom. And that's all labeled throughout our diagram on screen. So the right side of our heart receives blood that's low in oxygen from veins all around our body. Then it pumps that blood into the pulmonary arteries to become reoxygenated. Our left side of the heart receives this oxygen-rich blood from the lungs and then pumps it through the aorta. This is our ascending aorta on the diagram. And then it pumps back out through the rest of the body through a complex network of arteries and capillaries. While this blood is circulating through the body, it delivers oxygen, nutrients to a lot of different tissues through capillaries, and during that process it's also picking up carbon dioxide, different waste materials, and then pumps through the veins to return that deoxygenated blood to the right atrium, repeating that cycle over and over again. The heart also has 4 valves, and we're going to talk a little bit about how those work. So, our heart has 4 valves, and think about the valves working as a one-way road that keeps blood flowing in the same direction. The valves, that are also known as leaflets, open up and close back and forth, pumping blood throughout the heart, and that pressure that they're pumping through is controlled by our blood pressure. So our first valve that we're going to talk about is the tricuspid valve. It's positioned in the heart's right side between the right atrium and the right ventricle. Then we're going to talk about our pulmonic valve, which separates our right ventricle from our pulmonary artery. That's labeled PA on our diagram on screen. Our mitral valve, which is positioned in the heart's left side between the left atrium and the left ventricle, separates the two. And then we have our aortic valve. which separates the left ventricle from our aorta. We have a few different large blood vessels entering and leaving the heart, known as veins and arteries. Our veins are blood vessels that enter the heart, and arteries are blood vessels that leave the heart. So we know arteries as being red and veins being blue, but that's not realistically true of the heart. We just use those colors for diagrams, and the blue on our model represents deoxygenated blood. A web of different nerve tissues also runs through the inside of the heart, and that works on controlling the contraction and relaxation of the heart. And a protective sac, also known as the pericardium, surrounds the heart. So we've talked a little bit about the inside of the heart. Let's talk a little bit about the anatomy on the outside of the heart. So we talked about how the blood flows through our heart, and some blood flows through smaller blood vessels, which are called coronary arteries, which surround the whole heart. The coronary system is a separate system on the heart that keeps the heart nourished and oxygenated. The two main branches of the aorta are the right and left main coronary arteries that surround the heart, and they control not only how much oxygen and blood the heart gets, but also they control how much of force or that pressure is going through those chambers. So there's something called coronary artery disease, and that occurs through a variety of factors. When there's a buildup of plaque in our main coronary arteries, there's a decrease of blood flow that happens to that heart muscle. This can result in damage to the heart or a decrease in quality of life. So when that coronary artery disease is affecting our blood flow, or coronary artery disease, also known as heart disease to many people, there's different factors that affect that. So this plaque buildup can lead to different risk factors such as angina, arrhythmia, heart attack, heart failure, and much, much more. That buildup of plaque, which we're going to dive a little deeper into right now, is diagnosed with patients through a variety of symptoms and factors. So diagnosis through these different factors include EKG test, which is an electrocardiogram. So an EKG test records our heart electricity. The buildup of plaque through coronary artery disease usually causes a decrease in the heart muscle function. So what that means is that our heart isn't receiving enough blood, enough oxygen that it needs to function properly. So that can lead to a lot of heart risk factors such as heart attack or decreased quality of life, which we're going to dive into a little deeper. But these are usually diagnosed through early on symptoms. So a patient will go see their cardiologist and go through one or a series of tests to receive a proper diagnosis on the severity of their coronary artery disease. So, as I mentioned, an EKG test, or there's a stress test, which involves using the heart's activity live on a treadmill, using those same electrodes connected to your legs or your chest and your arms to monitor the function and activity of your heart. In ultrasound of the heart, the computer records different sound waves through an echo machine, and the doctor is able to see a live view of how the heart's functioning, how the valves are moving, how the chambers are working together. So those are how the diagnoses go with this kind of procedure. And there are various treatment options, but first, let's go into the risk factors that lead to this kind of disease. So when the plaque builds up, it narrows our coronary artery disease. It's decreasing that blood flow to our heart, and eventually the decreased blood flow may cause chest pain, which is also known as angina, shortness of breath, or other coronary artery disease signs and symptoms. A complete blockage in one of our coronary arteries can even cause a heart attack. But because coronary artery disease develops over decades, a lot of patients don't realize they have a problem until a significant blockage occurs. But there's a lot we can do to prevent coronary artery disease, such as a healthy lifestyle can make a big impact. We're going to talk a little bit about risk factors that lead to heart disease or coronary artery disease. So a first one and a big one is smoking. So smoking, people who smoke have an significantly increased risk of developing heart disease. Even exposing other people to secondhand smoke can also increase their risk of coronary artery disease or other risk factors. Another one is age. Simply getting older increases your risk of damaged and narrowed arteries. Another one with smoking involves vaping. Vaping is extremely risky along with smoking just because there's not a lot of research out on it and we don't know enough about the causes and effects of it long term. Exercise. So people who have a lot of exercise and a lot of heart activity decrease the risk of developing heart disease, but lack of exercise is also associated with coronary artery disease and other worsening risk factors. Another one is weight. So overweight or obesity, along with lack of exercise, can lead to that narrowing and that plaque buildup in your coronary arteries. Another one is DNA. So if you have a family member who had heart disease or a heart risk factor early on in their lives, that could lead to it being in your family trend or DNA. Another one is cholesterol and diabetes. So diabetes is associated with an increased risk of coronary artery disease, type 2 diabetes especially, and coronary artery disease share a lot of similar risk factors. Another one is stress. So unrelieved stress in your life may damage your arteries as well as worsen other risk factors for developing coronary artery disease. And the last one is gender. So men are generally at risk for developing coronary artery disease or another heart disease early on in their life. So now that we know some risk factors, let's discuss some treatment options. So treatment options depend on whether a patient has a severe blockage or a lower blockage. So there's minimal invasive heart surgery that involves making small incisions on the right side of the patient's chest to reach their heart. That doesn't involve an open heart surgery. So there's minimally invasive options, which we're going to play a quick video and you can get a bigger view on some minimal invasive options that don't involve open heart invasive surgery. Or what we focus here at the Liberty Science Center is on open heart surgery. In open heart surgery, a patient can stay in the hospital for up to 5 days, follow up with a surgeon, cardiologist, and other therapists. But as I said, the patient's severity depends on what treatment option they're going to get, whether they need surgery, or whether the severity of their surgery is dependent on the severity of their coronary artery disease. So I'm going to play this video. I'm going to pause a few times in between and I'm going to check back and see if there's any questions in the meantime.
Coronary artery disease occurs when the inner walls of the coronary arteries thicken due to a buildup of cholesterol, fats, calcium, and other elements carried in the blood. This buildup is called plaque. As this plaque develops, the blood vessel narrows. This restricts blood flow so less oxygen and other nutrients reach the heart muscle. The disease can be detected and evaluated by a test called a cardiac catheterization. The test gives the cardiologist accurate information to determine the best course of treatment. The The cardiologist usually performs this procedure in a sterile room called a cardiac catheterization laboratory. A long thin tube called a catheter is inserted through a small incision, usually in the patient's groin. It is carefully guided through the femoral artery to the heart. A connector allows the doctor to pass different devices into the coronary arteries to treat the plaque. A radio-opaque dye is injected through the catheter, and its flow is detected with an X-ray machine called a fluoroscope. Multiple views allow the cardiologist to evaluate the health of the patient's heart, including the identification of narrowed or clogged arteries. Intravascular ultrasound is used in conjunction with an angiogram, both to view images of the inside of the arteries and measure the diameter of those arteries. An imaging transducer is advanced to the lesion, and imaging begins along the length of the lesion. These images aid the cardiologist in determining if blockages are severe enough to warrant treatment and to determine what that treatment will be. Intravascular ultrasound can also be used to image the treated lesion and ensure the desired result was obtained. Common treatments for coronary artery disease are medication, balloon angioplasty, stent implantation, rotational atherectomy, and bypass surgery. Some blockages can be treated immediately following diagnosis in the cardiac catheterization lab. If diagnosis shows that blockages are severe, the patient is recommended for bypass surgery. All procedures are designed to improve blood flow through the coronary arteries and thereby reduce the risk of heart attack. Balloon angioplasty is designed to push the fatty plaque back against the arterial wall to make more room for blood to flow. A catheter with a balloon at the tip is inserted into the femoral artery and is threaded to the site of the blockage.
So just to give you a little catch-up, I know they're using more advanced medical terminology. So a balloon, in this case a medical grade balloon, is used to open or narrowed or blocked blood vessels of the heart, known as our coronary arteries that you're seeing on screen right here. So this long, skinny, slender tube is called a catheter, and it's going through with the balloon deflated at the time, and is passed through this coronary artery, and then it's inflated.
The balloon is then inflated
with something called saline, which is another medical grade liquid that's sterile, and it just inflates to narrow and widen that coronary artery, kind of clearing out that blockage. Afterwards, the balloon is then deflated, and the saline and the catheter is removed,
forcing the plaque against the wall of the artery. An increase in the flow of blood is seen immediately. The balloon may be inflated several times during the procedure. An additional option is stent implantation. Stents are wire mesh tubes designed to hold the artery open. They are typically inserted on balloon-tip catheters and deployed by inflating the balloon, leaving the stent embedded in the wall of the artery. Just as scaffolding supports a weak building, stents support the damaged artery walls, reducing the chance that the vessel will close again. Another treatment is rotational atherectomy. This procedure actually cuts away.
So I'm going to pause really quick. Tanika had a really good question. Oh, Bree and Tanika had a really good question. Are the people put to sleep in this surgery, or are they awake? So they are put to sleep under anesthesia. So we're going to go into a little bit about what an anesthesiologist does and the bypass surgery. And that's going to be our next procedure we're going to look at after this.
Some of the plaque lining the artery. The physician is likely to choose atherectomy when the plaque is very hard and calcified. Rotational atherectomy uses a rotablator with a burr at the tip. The rotablator head rotates quickly and grinds the plaque into very small particles. In most cases, these microparticles can travel safely through the circulatory system without causing any problems. The size of the burr can be increased to enlarge the size of the arterial opening. Coronary.
So what they were saying, the burr, that very small drill, is placed inside the coronary artery as well, and it can only be used on calcified plaque. So what I mean by that is plaque that has been hardened to the point that other procedures won't work, such as the balloon angioplasty. That works on plaque that's developed early on.
Coronary artery disease remains the #1 health problem in the United States. In the past few decades, cardiac catheterization has become one of the most commonly performed medical procedures. Balloon angioplasty and stent implantation can be effective for many patients. However, in certain patients, coronary bypass surgery is the only option.
Okay. So, we learned about those minimal invasive methods. Before I move on to the open heart method of surgery, also known as coronary artery bypass surgery or coronary artery bypass graft surgery, I'm going to just check in my Q&A. Do I have any questions about what you just saw in that video, about those 3 procedures, the balloon angioplasty? Anything about the drill? Any questions? Johnny wants to know if any of these procedures hurt. So luckily the patient is under anesthesia, so the patient is prepped and put to sleep. Once the patient wakes up, he's not able to feel any pain or even have any recollection or memory of even having that kind of surgery. The process isn't painful for the patient at all. But that was a really great question. I'm just going to do another look in our Q&A. If you have any other questions, you can ask, or I'm going to hold off to the end and go into our Q&A. Okay, so let's talk a little bit more about that invasive surgery method, that coronary artery bypass graft surgery. So we know what coronary artery disease now. It's that narrowing or blockage in one or more of the coronary arteries. And our coronary arteries that cover our heart, they supply that oxygen-rich blood and those nutrients. So in this kind of procedure, it's very common that one or more blockages are happening. So in this kind of procedure, the patient has to have a severe case of coronary artery disease, enough to have one or more bypasses or grafts created. So what this surgery entails is pretty much think about the heart right now as a highway. So we talked about those chambers in our hearts, those leaflets, those valves as a one-way road. Now think about the coronary arteries as a highway system. So if we're driving down the highway and our coronary arteries are that road we're going down, say there's a large accident, there's a buildup, there's a lot of traffic, that pileup of cars. The pileup of cars, in the sense, is that plaque, that buildup. And right now, there's no way to get through it. We've tried to go straight towards it. We can't back up. The only way we can really go around it is by creating a pathway or to go around it through a detour. So that's what this surgery is. This surgery involves creating a detour around these coronary arteries. So I'm driving down this highway. I'm driving down my coronary arteries. There's that traffic, that buildup of that plaque. I'm going to create a detour. I'm going to create a bypass. So a new pathway in this surgery is being created. A new vessel is taken from either something called our internal mammary arteries that we're going to go into, a vein from our leg known as our saphenous vein, or a radial artery from our arm is taken, and that's that graft that's going to be created. That's transplanted from one part of our body and attached to our heart to create another pathway for blood to travel through. So, we're going to go into a little bit about this procedure. We're going to look at some images of the open heart surgery. So, this surgery involves opening of the chest cavity to reach those internal mammary arteries to see how severe the coronary arteries are blocked firsthand by the surgeon. There's that preparation of the conduit, so the internal mammary artery or the greater saphenous vein. The conduit is our graft. Our conduit is also known as that bypass that we're going to create. Then the transition to bypass, which is a heart and lung machine monitored by someone in the OR team. So that person in that OR team is going to put the heart onto the bypass machine, which is going to pump for the heart, and it's going to stop the heart for right now. And then it's the surgical bypass, so that creation, that connection by the surgeon of those blockages, and then finally the closing and suturing of the chest. So what happens during coronary artery bypass surgery? So at the beginning, the patient is prepped, cleaned, and gotten ready for surgery. The first part of the operation, once the patient is prepped and asleep, the patient's going to receive general anesthesia to be put to sleep during the surgery and different medications during the surgery. And a big role in the surgery is the anesthesiologist. As you're seeing on the screen, that's one of the stations the anesthesiologist monitors throughout the surgery. And the role of the anesthesiologist is to monitor the patient's breathing, how asleep the patient is, and the medication they're receiving throughout the whole surgery. So, as I said, the first part of the operation, once the patient is prepped and asleep, is obtaining the conduit for the surgery. In a lot of these surgeries, the surgeon usually uses both internal mammary arteries, and I'm going to go over what that is on the next screen. So our internal mammary arteries are usually the most common grafts used for these bypasses. The goal for these arteries being used is usually because they're the most durable. They're already on the chest wall, so it's the easiest to make that transplant. So our internal mammary arteries lie on our chest wall, and they're usually the best in long-term results of creating these grafts because they are very strong, they have a very strong blood flow, and they're already close to the heart. So we have 2 IMAs in our chest, and if these are usually used for the surgery, they can usually be kept intact at their origin because they already have an oxygen-rich blood supply. So the other end of the IMA is just connected to the coronary artery below that blockage, and if it needs to be removed, it'll be removed and then transplanted from one side of the blockage to the aorta. The other artery that's commonly used in surgery is the radial artery, and that's in the arm. That's another common graft to use. So if the IMAs are not enough, if more bypasses need to be done, the radial artery from the arm is going to be taken and used as a graft. So if the surgeon decides to use the radial artery, a few different tests will be made to make sure that's the proper one to use versus the saphenous vein. It'll be cleaned up, any excess branches will be cut off, any excess tissue. It will be removed, and it will not harm or affect the arm in any way. The arm has other strong sources of blood flow that will be adequate enough to be able to use this for this kind of graft, for this bypass. And the last one I'm going to talk about is the saphenous vein. So the saphenous vein, it comes from our leg, and this is the smallest invasive procedure of harvesting a vein. So it doesn't require a long incision. Instead, 1 to 2 incisions are made, one at the knee and one at the groin. And this type of removal of the saphenous vein for the surgery involves less scarring, less effect on the patient versus taking it out of the arm. And that's also more commonly used than the arm because it has, again, a stronger blood flow than the arm, and it's just a more durable vein than the radial artery in the arm. So it's more traditional to be used is the IMAs, and then the saphenous vein, and then usually at a last resort, or depending on the quality of the vein in the IMAs, the radial artery will be used. On screen, you can see the saphenous vein, which is usually harvested by the physician assistant. So we're going to go over the OR team at the end of this, but in this procedure, there's a large OR team, and the physician assistant assists the surgeon the whole time during the surgery. So while the surgeon is working at the top of the patient, inside the patient's chest, either harvesting those IMAs, our physician assistant is harvesting those saphenous vein. So once we get that vein out of the leg, this is a final, ready to go saphenous vein. It's been cleared of all its branches. The physician assistant will inject it with some sterile saline to see the quality of the vein. So that saline, that sterile fluid, he will cut off any excess branches, any excess tissues. He'll reinforce them using something called suturing to close off those extra branches and reinforce it to be stronger. Here's another example of that saphenous vein, and that surgeon putting on those stitches to close off any of those excess branches. So the next image I'm going to show you is a little gory. You're going to be seeing the heart opened up in the middle of the surgery. So this process for opening up the heart is used by having a sternum saw. But before I go into that, you might see the skin around the patient, around those big metal clamps. It looks a little funny. That's actually something called a bi-drape. It protects the layer of skin. It's kind of like a sticky plastic covering, and that protects the patient and that layer of skin from any microorganisms or other bacteria. So to get into the chest, our surgeon creates an incision of our patient, probably the size of from our pinky to our thumb, if you hold your hand out like this, and you put your thumb in that little... Hello, everyone. I apologize for that issue. We had a minor technical difficulty, but hopefully you can hop right back on and we can continue and get started. I apologize again for anyone joining. We had a minor technical difficulty, but we're right back here, ready to keep going and get started. I'm going to give it another minute until I hop right back in where I was. Okay, again, so sorry about those technical difficulties. I hope we're ready to just dive right back in to where we were. I'm going to give it a few more seconds, wait for some more people to join. We were just getting to the juicy stuff too, and we just had a minor technical issue, which is fine. Sometimes in the OR, we have some technical issues when we're presenting live, but we just hop right back in and keep going. Okay, so as I was saying, if you take your pinky and your thumb kind of in that luau motion, so you have your thumb right here, and if you put in that little indent in your neck and put it straight down your sternum, the front of your chest, that's about how big that incision site is. So those doctors are working in a very small, tight-knit area. Then those tubes that you're seeing, I'm actually going to show you. That's the tubes connecting the heart to the heart-lung machine. They're usually of different size and different shape depending on the heart, but that machine is pumping blood to the rest of the body for the heart at the time while it's connected and on surgery. So, like I said, we have a clearer view of the heart once it's opened. Those metal clamps are called retractors that not only gives the surgeon a better view of the heart, but also those IMAs, those blockages, and that little area of yellow roundness that you're seeing on screen, that's actually the heart. As I said, that our heart has a lot of fat surrounding it, and that's just protecting our heart. So, after our surgeon makes that incision down the center of the chest through the sternum, he uses a sternum saw to cut through that breastbone so that our coronary arteries, our whole heart is able to be seen. And the heart is stopped for a short amount of time using that heart-lung machine. So the surgeon can perform the procedure on a still heart, a heart that's not moving and not beating at the time. So the bypasses are placed on the heart in different patterns. It's placed by sewing one section to the coronary artery or vein around the tiny opening below that blockage in that diseased coronary artery, and then by attaching the other end to a tiny opening made in the aorta. This redirects that blood flow around that blockage, and if that IMA artery is used, one is connected to the coronary artery and one stays attached to that aorta. So during that surgery, the surgeon may place something called temporary pacing wires and a chest tube before the sternum is closed using special metal wires. And our lungs are actually deflated in this surgery right before the sternum saw goes through, and that's because we don't want to cause any damage to the lungs or any other tissue. So right before that sternum saw goes through the center of the chest, those lungs are deflated. The second view I'm giving you is a better view of those retractors, that inside view of the heart, that zoomed in view, and those tubes you're seeing coming out of the heart are connected to that heart-lung machine. So the perfusionist, another really important role in our surgery team, monitors that heart-lung machine. He keeps track of how much blood is coming in and coming out. And those retractors help access those IMAs, those internal mammary arteries on that chest wall. So the internal mammaries are really strong. They last a really long time. And like I said, they're the priority candidate to be used in getting those conduits. So the station that you're seeing right here is our perfusionist station. So our perfusionist has that main task of keeping track of how much blood is going in and out of the heart. He's keeping track of all those monitors in relation to the heart and lung machine. So just to give you another quick overview, we have that heart, we have those tubes in and out, and that pumping of blood. So like I said, our OR team consists of a lot of different people. Our physician assistant, our surgeon, anesthesiologist, our perfusionist, our circulating nurse. And during these live from programs, students are able to interact with the whole OR team. They're able to ask anyone any questions. They hear a lot of really cool background stories. But if you're interested in a career in medicine and don't necessarily want to do hands-on patient care, there's career options in biomedical engineering where you're developing either vaccines or medicine, as well as chemical engineering or chemistry or education in biology. You can work in a lab. You can work in an engineering location. So biomedical engineers make things such as prosthetics, surgical gear being used, surgical equipment, wheelchairs, stretchers, ambulance equipment. Paramedic is an incredible field that you can go into. You work in a 911 setting for a hospital, so you respond to 911 calls, and you provide an advanced level of care. Your care is about equal to the same education that a nurse receives in that kind of setting. A nurse option in different settings of the hospital, different locations. Surgery is an incredible option. Myself, I've been an EMT for almost 4 years now. I became an EMT through volunteering at my town's local ambulance corps. I went to EMT school when I was 17 and started my first job at a hospital towards the end of my senior year of high school. And that's what really motivated me and got me extremely interested in medicine. So if you want to pursue a career in medicine, I definitely recommend you all to just follow your hearts and continue on the path that you really want to go on, especially if that involves something in medicine. So I'm going to take this last time to answer some Q&A questions. So about right now is when I'm going to take any questions or comments you may have in our comment section. So Max says, are any 3D printed items used in the OR? So if they aren't used in the OR, they're used in other sections of the hospital. So for example, right now with everything going on in the hospital and a decrease in medical supplies being available, a lot of incredible people who don't even have a career in medicine are stepping up and 3D printing these medical supplies for hospitals and healthcare workers to use. So someone asked if I went to med school. So no, I haven't gone to med school. I'm a STEM educator here at the Science Center. I did go to EMT school. So that qualifies me to be an emergency medical technician here in the state of New Jersey. So what I do as an EMT, I respond to 911 calls, I provide immediate patient care, I work with paramedics on scene, and then I transfer that care in the emergency room or that hospital setting. If it's a choice between angioplasty and bypass, which is recommended, so I can't really recommend an option for you, but like I mentioned earlier in the other portion of this lesson, that it depends on the severity of the patient's coronary artery disease and the severity of that buildup of plaque. Can I answer any questions for anyone? Anyone interested in a career in medicine? Definitely shout it out in the comments. We have a lot of really cool lessons coming up on LSC in the House and a lot of really cool sneak peeks into our Live from Surgery program within the next few weeks. So I'm just going to hang out for the next few minutes. I'm going to be answering any questions anyone may have. Any comments? Okay, about how many years is an invasive cardiologist residency and fellowship? So I don't know the exact number of years, but I know you do your 4 years of undergrad, your 4 years of medical school, and then your residency. Right there, that's about 10 to 12 years. After that, you go into your specialty, which, depending on the department, takes another few years. Does the patient choose what vein to use for the graft? So no, the patient does not, unfortunately, get to choose what vein they use for the graft. It's usually based on the surgeon. So the reason it's based on the surgeon is because the surgeon is able to get a better idea of what vein or artery will work best for the patient in their circumstance and depend on their health. So Jeremy wants to know, how do we reduce stress? And someone else said, what are the best foods for the heart? So I'm going to go with the foods for the heart first. So everything in limitation. So definitely don't deprive yourself of the things that you enjoy, but on a daily, just try to make healthier choices. So including fruits and vegetables in your diet, less processed foods, less fatty foods. Usually there's some really good recommendations online that can tell you about really good diets to follow, but diet in association to exercise and living a little bit stress-free all works together in preventing some risk factors and preventing heart disease along with other health issues. And Jeremy says, how do we reduce stress? So you can reduce stress in a lot of different ways. I definitely recommend finding something you enjoy and making time for that, at least for a few minutes every day. So for me, I love yoga, so I'll try to do about 30 minutes of yoga every single day, or any type of exercise for me is an incredible stress reliever. And any exercise for anyone releases a lot of stress as well. As I said, in association to diet, exercise is a great factor in reducing stress and overall living a really good, healthy life. What is the difference between a girl's and a boy's heart? So everyone's heart is pretty much the same. We have about the same heart. The only difference between maybe my heart and your heart could be the size. My heart might be bigger than your heart or smaller than your heart. Your heart's about the size of your fist. In some adults, it's the size of 2 fists. So it just depends on the person. But anatomy-wise, all of our hearts are the same. Are there any custom surgical devices only used for cardiac surgery? So each surgery has their own specific equipment that they use. So for this surgery, we saw a little bit of that retractor, that bypass machine, that heart and lung machine. Do I have any recommendations of an online class or tutorials? So unfortunately, I don't have any recommendations on to learn how to read EKGs. Usually in medical schools or medical training programs, they do teach you. So maybe YouTube is a great resource, or just any professional medical website. Okay, I want to say again, thank you all for joining me today. I apologize for the technical issue we had earlier. We're going to work out any kinks that we may have. But thank you all again so much for joining me, and check us out on LC in the House. I hope you're all staying safe indoors. Remember those risk factors I talked about, and with anything, especially if you're interested in pursuing a future career in medicine, just follow your heart. Okay, goodbye everybody.